Okay, so I shortened myself a little bit for this, but that's good because we're going to talk about immunotherapy in GYN oncology, and the truth of the matter is this is very much a theoretical talk because the data we have for it is very theoretical. There's really no definitive data, like we heard this morning with breast cancer, that immunotherapy is going to be the game changer that we have seen in other disease types. So my disclosures, I have no financial disclosures, and I am not an immunologist. So I'm going to do my best to walk through some of the really, really dense sciencey stuff, but really all we have is really, really dense sciencey stuff because we have no clinical data necessarily to show anything definitive. So immunotherapy, this is a new kid on the block. This is the next greatest thing. And the journal Science in 2013 said this is the breakthrough of the year. This is going to change the face of cancer therapy for everybody. And in some disease sites like melanoma, it has. But this editorial that they published had a hint of once bitten, twice shy, if you read it, because we've been here before. Cancer and the immune system have a very complicated relationship, like two ships crossing in the night that just could never get their act together. It's complicated. There's been hints that things were related and a better understanding of immunology was going to change the face of cancer treatment, and here's a brief history of that. In the 1890s, a guy decided to inject bacteria into tumors and they shrunk, and he won the Nobel Prize. So certainly that was going to get translated immediately to cancer therapy, and it didn't. In the 1900s, we had another guy who postulates this idea of immunosurveillance. So we've all heard it, right? Your body probably has cancer cells that are popping in and out of existence every hour, every day, all the time. Your immune system plays a role in identifying those things before they ever cause any trouble and getting rid of it. That's called immunosurveillance. That idea existed in the early 1900s. We didn't see evidence of that until we did a bunch of mouse experiments in the 1950s and the 1960s. So certainly we're on the precipice of finding something amazing. 1980s, we discovered CTLA4. We'll learn about that later in the talk, but basically had nothing to do with cancer research. It was just a little knob that allowed you to turn down the immune system in autoimmunity. That was discovered in the 80s. In the 1990s, putting all of this stuff together, we finally have some clinical data looking at immunosurveillance and maybe treating cancer patients with immunotherapy. So the discovery of interferon and the use of peptide vaccines. We put it in everybody, and it didn't work, and it was really toxic, and we just really didn't understand what we were doing because immunology is a very difficult thing to learn. It's a very difficult thing to get a handle on, and somewhere, somehow, Einstein is laughing at us because it's all relative. You cannot understand how the immune system is functioning in cancer without understanding what's going on in the cancer. It's very context dependent. And that is what ultimately has changed our perspective and why right now there is a sea change in the way we use immunotherapy and why it's been so successful. We've changed our focal point. Unless you understand what's going on in the tumor microenvironment, you're never going to understand how immunotherapy is going to work. And what we found was the tumor microenvironment is full of immunosuppression. The immune system is not allowed to work. And so jumping on that idea, we've really seen some clinical change. So we'll do a quick, very, very brief primer on immunology. We'll learn to speak the language, and then I'll kind of go through what data there is in GYN cancer and what the future holds. So the battle for staying alive, right? We are constantly under attack by a variety of things, viruses, bacteria, fungus, cancer. The role of the immune system is to recognize all of these things and get rid of them before they cause any trouble. So what is the primary goal of the immune system? In order for you to recognize outside pathogens and kill them, you have to recognize yourself. So one of the primary goals of the immune system is identifying what belongs to you and what looks like a space invader so that you can kill it. So what are our lines of defense to do that? There are three lines, right? In two compartments. We have our innate immune system. That's what we're born with. Not Nate Jones, but innate, right? The first line of that are barriers. We built a wall. We have skin. We have mucous membranes. And I would argue the microbiome probably plays a role here, but we won't get into that today. Second line of defense are your army guys, the neutrophils, the white blood cells that are your first responders that identify something immediately, go to the front line and kill it. And then you have your adaptive immune response. That's our third line. That's the specific immunity that identifies that specific virus, that specific tumor cell that could come in and save the day. And just to look at it a little more schematically and what tools we have in the toolbox, the barriers again are skin and mucous membranes. In the innate column, you have your rapid response. These things take minutes. The neutrophils that are there are your first response or first response to any pathogen. You also have your professional phagocytes, the things that are supposed to come in and pick up bacteria and viruses and kill it immediately. And then you have your dendritic cells, and now those are super important. The dendritic cells are your cells that are bridging this column to this column. Without your dendritic cells, it's hard to activate the adaptive immunity that really hammers the process home. Okay, so this is the immune system, right? That's not intimidating at all. So super complex, but if you take it in small chunks, it kind of starts to make sense. But the point here is that you start with a problem, whether that's bacteria, a tumor cell, or otherwise, and your innate immune system kicks in and starts killing all of this stuff, presents it to a dendritic cell that ultimately bridges to your adaptive immune response. So let's take the innate immune system first. Those are your first responders. Natural killer cells, those are the Jason Bournes of your immune system. They don't care what is there, they just know it's not normal, and so they kill it. Same thing with macrophages, monocytes, and neutrophils. And like I mentioned, your dendritic cells, those are the primary antigen-presenting cells. Those are the cells that are going to pick up your trouble, post it for everything to see, and let your T cells do the rest. And the point here is that these first responders are what are going to initiate the adaptive immune response, and they're also going to initiate the inflamed response. So all of this stuff is happening, all of these cytokines are getting produced all over the place, and what do you see clinically? You see erythema, you see increased permeability and swelling, you see attraction of leukocytes. That's what pus is. Those are your first responders trying to do their job. And you see systemic responses like fever. After you see that, that's when your adaptive immunity kicks in. So those dendritic cells are talking to your T cells. That's where we get CD4 and CD8 cells. Those are your effectors. That's the cavalry that shows up at the end of the day to take care of all the problems. So the dendritic cells present all of their antigens to your effector cells. Here are the CD8 cells. These are cell-mediated. This is cell-mediated immunity. So by cell-mediated, it basically means there is a cell that is going to kill the other problem, the other cell. Then you have humoral immunity. These T helper cells will move into B cells. That produces your antibody. So that's a humoral immunity. So you've got two arms of an adaptive immune response that are geared to come kill whatever your problem is, whether that's tumor, bacteria, or virus. So if you have this system set up, right, if we have an immune system that functions by surveilling and killing outside invaders, how is it possible that an immunocompetent person, somebody with an intact immune system, can develop a cancer? That's the whole point of the immune system, is to go out and identify something that doesn't match your own self and kill it. That's been the holdup with immunosurveillance, and the reason we've not been able to make any progress is that's how we've thought about the immune system. It's just out there kind of watching and patrolling, and if anything pops up, that's what it's supposed to do. But it was a change in perspective that I think has allowed us to kind of progress a bit, and it's a change in the understanding of the immune system. Instead of there being immunosurveillance, there's this idea of immune editing and immune sculpting, if you will. And all of this is happening at the immune synapse, and I won't get too deep into any of this because, again, I told you it was very deep and theoretical. But the point of this is you have a presenting cell, like a dendritic cell, that is trying to activate an effector cell, right? It's trying to make this cell go kill the tumor, which is right in here. Where the change in perception and where immunotherapy has really come on the scene is right in this area right here. So what we understand is that the dendritic cell is not only presenting a tumor antigen to the cytotoxic killer cell, it also has to stimulate it. And so basically it binds, and these other molecules have to bind as well. It's a two-step process to stimulate the effector cell to do its job. But what the tumor is also able to do is upregulate that knob, that turn-down dampening switch that allows itself to turn the immune system off. So that creates our immunosuppression, which is really the problem in a lot of immunotherapies, is that the immune system, you can give it all the activity you want, but unless you turn the switch to turn off the immune suppression, you're not going to get anywhere. And so this is what cancer immunoediting is supposed to be in several phases, the 3 E's of immunoediting. You start with normal tissue, you get transformed tumor cells, and this is immunosurveillance here, your elimination phase, okay? This is your mama's immunosurveillance. This is what we thought of in the 50s. This is the part where you have transformed tumor cells that are being surveilled by the immune system and killed. Your innate and your adaptive immune system come together and get rid of these cells every day. It happens your whole life. So that's good. We're able to control transformed cells. But in the equilibrium phase, this is the longest phase of what we think is immunoediting, you lose the ability to completely eliminate those cells, but you can contain it. This requires the adaptive immune system. So you're producing interferons and you're activating CD8 and CD4 cells. Those cells are killer cells. They can kill those tumor cells, but they can't completely eliminate them because the tumor has mutated, or the tumor cells have mutated enough to escape part of that immune system. And like I say over here, genomic instability is key. The more mutated these tumor cells are, the less likely your body can recognize it as self. So you escape the equilibrium phase because the tumor has then gained the ability to grow in an immunologically intact environment. And in order to do that, it has to invade innate and adaptive immunity. And we know that there are multiple mechanisms involved in this, and those are not well studied yet. But the idea of this is fascinating because what this is basically saying, I know it gets really complicated, but what this is saying is every tumor that is born of the landscape of the immune system that it was born in. So every tumor, theoretically, should have a stamp that says, I was born in this kind of landscape. The immune system has an imprint, which is really, really interesting and something that we've never really considered before. So what has to happen to escape the immune system? You have to have expression of these cytokines that turn off the immune system. You have to have expression of receptors that allow you to turn off the immune system. And you have to lose your identity to a certain extent, right? The cells that tell the other cells that we belong here disappear because the tumor mutates. So you get loss of MHC, which is that self indicator, that marker on a cell that says, I belong to you, it disappears. And if your immune system can't recognize it, then it continues to grow. So this is where we are with cancer immunotherapy. So we start on here with little step 1, where a dying cancer cell releases a bunch of antigens. Those dendritic cells we talked about picks them up. They prime the helper T cells and the effector T cells to start trafficking to the area to kill the tumor. You get that inflammation, that permeability in the vascular structures to allow the cells to get there. And then you get these recognition T cells that kill the antigen in the first place. And then this is that immune synapse that we talked about. So there has to be stimulation in addition to binding for all of this to happen. And in order to stimulate it, you have to turn off the inhibition. So that's what we've got, is a big culture, so to speak, of immunosuppression in a tumor. So how has that changed the clinical management of cancer? Well, if you look over here, we talked about CTLA4. That was the knob that turns down the immune system. That is happening right up here with these antigen-presenting cells. For an antigen-presenting cell and a T cell to bind, you have to also stimulate that activity, and that's what ipilimumab does. So that's where that works. You come over here, you've got an activated T cell that's trying to kill something. That also has to be stimulated. It also has a knob that it can turn off, and that's the PD-1 ligand. If PD-1 is upregulated, the immune system is turned down. So these are the 2 points in this process that we've been able to exploit with immunotherapy, and it has changed the treatment of melanoma. In fact, it has changed a lot of things, and if you look at the number of FDA approvals over the last few years, all of these are immunotherapies that are either CTLA4 inhibitors or PD-1 inhibitors. And this is more FDA approvals than we've seen in decades, really. So again, looking at all of this, now that we've learned that there's an immunosuppression problem, these are all co-stimulatory and co-inhibitory molecules that we're able to exploit with a variety of treatments. And you see we're discovering these quite rapidly. So what we're going to see, in addition to these CTLA4 inhibitors and the ipilimumabs and the nivolumabs of the world, are therapeutic vaccines. Can we change the way the dendritic cells present antigens to T cells? Can we give folks lymphocytes that are trained to attack a tumor? All of this stuff is coming into view because we have a better understanding of the immune system, much better than I can tell you today. So where are we heading? Again, we're getting rapidly approved drugs, 46 new FDA drug approvals in 2017. That's the most since 1996. And all of these, for the most part, are new drugs that are in the immunotherapy space. So from a GYN oncology standpoint, are we at a point where we can jump on the bandwagon? You know, immune checkpoint inhibitors are supposed to reactivate the immune system in that elimination phase. Cancer vaccines, there's no immunotherapy success that rivals the HPV vaccine that is underutilized. But therapeutic vaccines, is there a way to enhance that non-self recognition? Adoptive cell transfer, can we, like I said, can we give patients lymphocytes trained to attack their tumor, or can we train the T cells in general to recognize a tumor? We'll start with the checkpoint inhibitors. Again, not to get too deeply into this, the point with the CTLA-4 or the ipilimumabs of the world is that this molecule, CTLA-4, is an inhibitory molecule, and it competes with the stimulatory molecule, which is CD28. So if you add an inhibitor to that CTLA-4, then you only get stimulation. So you're only going to reactivate that immune system. So that's how those work. Originally shown to restore tumor immunity in melanoma. That means when given to a melanoma patient, their immune system killed their tumor. And it's been striking. It's changed the treatment of melanoma. PD-1 inhibitors are similar. Now these only work in activated T cells. So that two-step process had to happen for these to work. But it's the same idea. Once the T cell binds to the tumor, PD-1 and PD-L1 bind together to turn it off. And if you add an inhibitor to the PD-1s, then theoretically you stimulate the immune system back. So what do we know about this in GYN cancer? Well, in ovary cancer, we know it's a deeply immunogenic phenotype. At least some of them are. They stimulate the immune system because they're very mutated. They have a lot of antigen. Once things mutate, the body does recognize that a lot of that stuff is not normal. So there are a lot of different antigens that are presented to the immune system. We also have data that suggests that tumors that have a higher degree of CD8 effector cells in it, those women actually survive longer because there's more of an immune response. All of this stuff should suggest that immune checkpoint inhibitors are effective in ovarian cancer, especially the more mutated tumors, like those that have a BRCA mutation or those that have genetic mutations along that pathway. It also suggests there should be a role for combining this stuff with PARP inhibitors, like we heard this morning, and anti-angiogenesis, like bevacizumab. So the suggestion is there, but clinically, what have we seen? In early phase trials with monotherapy with, for the most part, PD-1 inhibitors, they've not been that great. There's definitely activity with response rates between 9 and 15%, but what I've highlighted here are a couple of trials using avelumab, which is a PD-1 inhibitor, and pembrolizumab, that is a PD-1 inhibitor. And we do see response rates in the 9 to 10% and maybe disease control rate in 50%, but we've not seen any overall survival changes. Where we think immunotherapy is probably heading in ovarian cancer is in combination with cytotoxic chemotherapy. And there is one trial that was recently completed. It's the Javelin ovarian trial that combined Doxil with avelumab, but it's not been reported yet, so we'll see what that shows. But there are a variety of other trials coming down the pike that are looking at combining this with cytotoxic chemotherapy up front, as well as PARP inhibitors. The thought being the more genetically unstable these tumors are, the more likely they are going to be to respond to some of the immune checkpoint inhibitors. But the data's just not there yet. Where does it stand in uterine cancer? We know with uterine cancer, we have a bunch of different subtypes, and there is a particular subtype that is going to be more susceptible to PD-1 inhibitors or immunotherapy in general, and those are the hypermutated endometrial cancers. These are the ones that have mismatch repair defects. So the agnostic indication for PD-1 inhibitors was given for patients that have mismatch repair, and this was studied primarily in colon cancer. But we know there's a subtype of uterine cancer that has mismatch repair defects as well. And the response rates of those patients to immunotherapy is actually pretty high, about 56%, which matches what the response rate is in colon cancer. So in those women with uterine cancer that have a mismatch repair defect, a PD-1 inhibitor actually looks like it's going to be helpful, though there's not there are not any reported clinical trials at this point specific to uterine cancer that says that, because that doesn't happen very often. So it's going to be a really hard thing to study. In cervix cancer, this is the one that's a little bit of a head scratcher. Cervix cancer is driven by a viral process. Cervix cancer should be entirely immunogenic. And when we try PD-1 inhibitors and CTLA-4 inhibitors in cervix cancer, there's not really been that much activity, which suggests the immune system, that context dependency of the immune system is different with cervical cancer, because it is a virally mediated disease. But it has been studied in phase 1 trials. There's not a huge response rate, overall response rates of 12%. What we are studying right now, and MCI is actively participating in, is whether or not radiation in and of itself can stimulate enough of an immune response for the PD-1 inhibitor to actually help. So we've got a trial going on right now that's looking at the sequence of radiation therapy with PD-1 inhibitors in cervical cancer. And that is accruing, and hopefully we'll have some data from that in the next couple of years. And then for vulva and vaginal cancer, there are basket trials right now, big giant basket trials that have arms for vulva and vaginal cancer, also looking at immune checkpoint inhibitors. That does include vulvar and vaginal melanoma, and there is phase 1, I think, data for those where it is promising, but again, very, very small and really hard to report on. And there is an active phase 1 trial right now looking at the combination of durvalumab, which is a PD-1 inhibitor, with tremelimumab, which is a CTLA-4 inhibitor, for all GYN malignancies. So we're kind of jumping on the bandwagon. We're trying to investigate all of this in GYN cancer, but clinically, we're kind of falling back into that same path that we've always fallen back to, where we have this great preclinical data and it all makes all of the sense in the world, but clinically it's just really hard to translate. Furthermore, for immune checkpoint inhibitors, how to follow them, how to measure the response, all of that is relatively new. And when we're only getting partial responses in GYN cancers, it's really hard to measure. But the toxicities are there, and that we can measure. CTLA-4 inhibitors definitely seem to have a dose response to their toxicity. PD-1 inhibitors less so. But I think the toxicities are similar to what you see in other disease sites. Dermatologic, GI, endocrine, pulmonary, neurologic, they're very, very real. And without definitive clinical evidence that these things work, it's really hard to make a decision to give patients that degree of toxicity. They are different than toxicities from cytotoxic chemotherapy, and they're generally well tolerated, but again, it's a consideration if we're not getting the clinical activity that we want. And then in terms of measuring response, there are no validated biomarkers that tell you these things are going to work yet. There has been investigation looking at the expression of PD-L1 and PD-1 in tumor cells that doesn't seem to correlate with response. What looks like it might be helpful in the future are tumor biopsies and looking at the infiltration of a tumor by CD8 cells before and after use of these immunotherapies. That seems to be something is probably going to be more telling than any particular expression pattern or anything like that, because it's telling you how the immune system is functioning. But the hard part in all of this, in addition to the toxicity, in addition to the response rates, is how do you measure it? Right? So I told you we get this giant immune response. We've induced inflammation, we've activated the immune system. So when you scan these folks, you typically see an enlargement in those target areas that you were originally looking for. So what does that mean? Does that mean that the tumor has progressed? Or is it just the immune response? So there need to be better, guidelines in terms of how to measure these things. And there's some out there. ASCO has some that I believe where you scan after 8 to 12 weeks, basically understanding that you're going to see an enlargement before you see anything get better. And that's all tumor site dependent as well. But the other thing is, even if that disease persists, right, if we have activated the immune system to put that tumor back into an equilibrium phase where at least you're containing it, does it matter that there's no shrinkage? Does it matter that the tumor size is about the same as it was to start with once you get that immune response? We don't know. So an active area of discovery. So again, immune checkpoint inhibitors, they definitely show activity in all GYN malignancies. The immune landscape of our tumors suggests you should see some responses, But like I mentioned, that really dense discussion of immunoediting, we don't know, we don't have all the answers, and we don't know how this stuff is supposed to work. We don't know how the tumor escapes the immune system in the first place, which then translates to the question that we don't know how to use these drugs in the right way, in the right combination. So that's going to get better. These things should work. We just have to figure out who is going to benefit, what the right combination is, and when is the right time to give it. And then, like I mentioned, how do you measure response? Now, beyond all of these things, because those are the new kids on the block, those are the heart therapies that everybody is getting. But beyond those, is there anything else? So again, based on what we've learned about the immune system, there's development of therapeutic vaccines. This particular antigen, NYESO1, is an antigen that is expressed on fetal ovary, the testis, and the placenta, but is detected in a wide variety of tumors, especially ovarian cancer. So they have designed a vaccine with this particular tumor antigen that has looked promising. And the way they're given it is also really interesting. You give this vaccine with inhibitors of methylation. We know ovarian cancer in particular is a hypermethylated phenotype. So if you're giving the immune system a little hint to go in and fight something, you also have to fight the landscape of that tumor. So they're combining this vaccine with inhibitors of methylation as well as PD-1 and CTLA-4 inhibitors. And I think that's the kind of stuff that we're going to see in ovarian cancer, especially for any of this stuff to really have a clinical impact. There are also whole cell vaccines, and MCI is participating in a trial of this, which theoretically allows the immune system a wider exposure to tumor antigens as opposed to just picking one. You pick a whole tumor cell and expose the immune system to that. It's theoretically supposed to give you a broader response, and it personalizes that immune response to the tumor. So here is how that works. At debulking, whether optimal or interval or neoadjuvant or primary, I don't think it matters, JYP, I'm looking at you. You take a piece of tumor out, right? You lyse all of the surrounding cells, that what you want are the tumor cells. You also draw some blood. You essentially dilute out the dendritic cells. Those are the bridge, right, between your innate immune system and your adaptive immune system. So you draw blood, you separate out the dendritic cells, you get your tumor antigens from your tumor, and you let those things kind of sit and hang out together for a while, right? You're exposing those dendritic cells to the tumor antigens. Now those dendritic cells are expressing those tumor antigens on their head, right? And when you give that vaccine back, they already know what the tumor antigens are, and you're supposed to activate the immune system specifically to those tumor antigens, which are specific to the patient's tumor. So in a phase 2 trial, looking at a vaccine like this, with primary debulking surgery followed by carbotaxol times 6 cycles, our soup du jour, these patients were randomized to get placebo versus a vaccine. And in a phase 2 trial, the disease-free interval was significantly greater in women who had received that vaccine than women that didn't. And it was really the only, correct me if I'm wrong, Rod, the only trial of a maintenance therapy in ovarian cancer that has shown any benefit from a progression-free survival. So that was really exciting, and so they moved it into a phase 3, and that's something that we're participating in, or had participated in, because it's closed. We're just waiting on results. But essentially, our patients, we take to the OR, take out some tumor, draw some blood, send them off. They would grow them up, let those things kind of hang out together, and then after the completion of therapy, if they were in remission after the end of the primary therapy, they would get a vaccine. So we're waiting to see what the results of that are, but in the meantime, there's a new trial that's combining this with an immune checkpoint inhibitor, right? So you're taking 2 arms of those things that we have learned, activates the immune system, and you're combining them together to get a better result. We also have a trial looking at this in cervix cancer. So this one is really interesting. This is taking bacteria. So we learned in 1890 somebody put bacteria in a tumor and it shrunk. Well, this is taking listeria, or taking the antigenic part of listeria, and basically plugging it into a dendritic cell and making a vaccine out of it. So the immune system is kind of tricked into reacting to listeria, but what it actually has on it is a fusion protein that is targeting the tumor. So it's reacting to the listeria, but it's attacking the tumor. And that's a trial that we've got ongoing at MCI as well, looking at this listeria vaccine in cervical cancer patients who have recently completed their primary therapy. In their original trial, they found a 38% 12-month overall survival, and if you look at the greatest trial there is in recurrent cervical cancer, which is GOG 240, that progression or overall survival matched the overall survival in GOG 240, which is carbo, Taxol, and bevacizumab, and that's the only thing that's ever shown any improvement in overall survival in cervical cancer, yet we now have this vaccine that is matching that. So are we going to see immunotherapy progress in cervical cancer? Probably so. We just have to figure out how to use it. And then there are a bunch of other really cool things that we aren't doing necessarily in GYN cancers, but I think is on the horizon. This adoptive T-cell therapy where you take tumor, you take lymphocytes, you teach these lymphocytes how to react to the tumor, and then you give them back. And you hope that those lymphocytes have been trained to start attacking the tumor. And this was done in the 90s for a good long while, but what they didn't do was basically give chemotherapy in between before you give it back to kill all the bad T cells and give back the good T cells. So that is on the horizon. And then this stuff is really cool, but again, I think is kind of a pipe dream right now for GYN cancers, which is this CAR T therapy. It was in the news. Basically what they're trying to do is change the way a T cell receptor acts. So they're training the receptors to recognize particular tumor antigens, and then you give those T cells back and they start killing the tumor. So all really exciting, but like I said, you know, it's been really difficult to translate clinically. It has changed the face of melanoma therapy for sure. We're just not quite there yet with GYN cancers. But it's changing the landscape of therapy, but the key is we don't just blindly jump on the bandwagon. The important thing is understanding how that immune system is working to understand how these things and all of these fun, really expensive, but really cool tools are going to work to kill the tumor. So that's all.